Hey, thanks again for welcoming or coming back to Arachnoiditis Unfiltered. This is episode 17, and we have the great honor of having Dr. Tennant, who I consider the GOAT of arachnoiditis. From a knowledge perspective, we hope to impart as much good information upon you as we can. Also want to say that we want you to go in and log your disease into Rare Patient Voice. We need everybody to log in with arachnoiditis so that we can track the disease. We can get clinical studies. We want a cure. That is totally what Sarah and I are looking for. And I'm certain 100% that Dr. Tennant wants that as well because of what he's been doing with this. And the best part about today is having him in September for National Pain Awareness Month. This was started back in 2001, and those of us that suffer through chronic pain, it is so important that people understand how life-disrupting chronic pain is. So, without further delay from me, I'm going to let Sarah introduce the very famous and very well admired Dr. Tennant.
Yes, and I just kind of want to go over his history really fast in case somebody's watching and doesn't know who Dr. Tennant is. I'm going to kind of go brief now just because I don't want, I mean, you guys can look up his history in depth online, but he got his medical degree in 1966. He is the world's leading expert in arachnoiditis. 50 plus years in pain management. I mean, that is a great accomplishment in itself. But you have authored over 300 research articles. You have books in which I have clinical diagnosis one here, and then the handbook one also, which we'll put a link so that if anybody's newly diagnosed, this handbook is a great reference. Moving on, Lifetime Achievement Award, consultant for DEA, FDA, and your pain management for the Dodgers, right? And NASCAR goes on and on. I mean, expert witness for Elvis and Howard Hughes. And without further ado, we are now to Tennant Foundation, in which if no one knows what that is yet, if you guys have chronic back pain that is unrelenting and you do not have a formal diagnosis, I do urge you guys to go onto that site. He has protocols on there. And as well as just look up the diagnoses because I think it's underdiagnosed personally. But anyways, you can find him on Doc Talks on Facebook. If you go under files, all his protocols are there. And also YouTube or Rumble for his podcast, which I think he's on year 3 of those. So there are a lot that you guys can get education on. And he's partnered with ACMCRN, which they are doing, they continue the advocacy for arachnoiditis, as well as ongoing research and studies for our disease. So without further ado, welcome Dr. Tennant.
Thank
Yep.
you. Let me say, I'm not only delighted to be here, I'm just delighted that you and Steve have started Unfiltered Arachnoiditis. We need you, and your goals are the same as mine, and I think everyone who has the disease. So I'm not only delighted to be here, I'm here to say thanks for starting this show, and I wish you the well, and will support it in every way I can.
Thank you.
Awesome.
Thank you so
Thank
much.
you.
Um,
Go
I,
ahead.
I just lost my train of thought. That's my mental fog. I'm so-
I call it Dory brain. But I was going to ask, first question, like what inspired you to go down through pain management all the way to arachnoiditis?
Actually, my although I'm a physician, internist by background, I guess my real interest started when I was a U.S. Army surgeon during the Vietnam War.
oh,
And I got interested primarily in the Army, more in addiction than I did in pain. And I was one of the first people to start up the urine testing, the methadone programs. And how we got started with intractable pain had to do within the 1970s, we started methadone programs primarily for veterans, but then it spread, and I was pretty much in charge here in Los Angeles of all the methadone clinics. And what happened, in fact, I remember almost the day, because once you dealt with methadone and true addiction, not this pseudo addiction, opioid use disorder nonsense. When you deal with true opioid addicts, these people know they're addicted. They know who they are. And I remember one day I had a longtime addict come to see me and says, "Doc, I need to talk to you." And I said, "Sure, what's up, Harry?" And Harry said, "There's a lady here in this line who doesn't belong here. She's not an addict, but she's here in the methadone line. What's she doing here?" Because the addicts knew who each other were, and they knew that there was a woman in the line who wasn't an addict, but she was there to get methadone. Make a long story short, we started finding out in the 1970s that people with severe intractable pain couldn't get help, so they started going to the newly established methadone clinics. And so we started, and the people that identified these people were the addicts themselves. They said, "No, this person," and they went, and I said, "Why don't you go talk to her and find out what the situation is?" And the addicts themselves started talking to people who were coming to the methadone clinics who had severe pain. So what we did was pull them off, set up a special clinic for them, and that was in 1975, and that clinic existed for up until around 2016 or 17, at which time the government no longer allowed it.
Oh,
Yeah, I mean,
didn't realize that.
so here you mentioned the government, and I have Sarah and I are really trying to lobby to get in front of Congress to talk about alternatives for pain management because they've shut the tap off for opioids, they've demonized it, and they're giving us very little hope that we're going to be able to deal with our pain going forward, that we're just going to have to suffer through it needlessly. And the whole medical credo is do no harm, right? But Congress doesn't care. Um,
Correct.
we really think that alternative medicines like ketamine are kind of the wave of the future as far as non-addictive, although, we had Matthew Perry perish from it, sadly. But when controlled and when utilized, I personally take no pain medication. I just have a very high tolerance for pain, but I still have those days that I have to simply survive, and they can go on
Sure,
72 hours.
you
And
bet.
I just have to, I just have to know that the pain's not going to kill me. I just have to make it through to the end. But I don't like to suffer. And Sarah had just undergone ketamine infusion,
Yeah.
which has done wonders for her with few exceptions, but it's not FDA approved for chronic pain, although they know that it works for chronic pain. How do you see us being able to work with that and kind of get through that barrier since you've had so much experience in this area?
I think at this time we have to go down all the roads. I do believe that the government realizes they made a terrible mistake in trying to outlaw high dose opioids, and they're kind of slowly reverting back to where it used to be. And we need to keep that up because we're still going to need opioids for some people.
Yeah.
Yeah.
Secondly, as you know, I'm a great champion of the alternative treatments. And in fact, opioids should only be used when the alternatives don't work. So my foundation and we've now, when we closed the intractable pain clinics, I've done nothing but do full-time research on arachnoiditis, and the real thrust has been developing alternatives to opioids because first off, the only way you deal really with pain is to treat the underlying disease, get rid of the disease, get it under control, but
Yeah.
you still need the ketamines, you still need the ivermectins, the PEAs, the torodols, the corticosteroids, the hormones. We're going to need all of these things. But I do think that since you brought it up, let's cut to the chase real quick. If anyone is sitting around waiting for the government to solve our problems with this, you're going to wait a long time. I see no effort in either state governments. Actually, some of the state medical boards are starting to really get on board. But at the federal level, I see no efforts there to help us at this time.
Yeah.
And, uh, and I don't know exactly why, but I do think that just like your show here, people who have the disease, the practitioners who want to practice, the people who want to do research, we've got to get together, circle the wagons, work, go forward. That's what I'm saying. And frankly, when I look back, when we started Arachnoiditis Hope about 8 years ago, at that time, I mean, arachnoiditis was a spider bite. We've come a long ways, baby. Now we got a long ways to go, but we've made tremendous strides. And let me tell you where we've made our biggest strides. And that is patients who have had the disease and families who deal with the patients have educated the medical profession. If you want to deal in America's medicine, you must understand something. And this is the most poorly understood thing that we face today, and that is the continuing education for postgraduate doctors does no longer exist. And in other words, people think that they can just go get FDA to make a regulation or DEA or the AMA or Blue Cross or somebody and things are going to be fine. That's not true. In other words, you said something here, Steve, on starting to show we're looking for a cure. Sure we are. And I call it near cure, if not a cure. And we're getting closer and closer all the time, but we're getting there because doctors today, I remember if you'd have come to me 15 years ago and a patient came in and handed me a brochure or talked to me about a disease, chances are I'd have sent him out the door. Not today, because I know that patient probably has come across something I no longer can access. You got to remember there's no more continuing education seminars, workshops, conferences, hardly for postgraduate MDs. And so doctors today are changing. They're kind of happy if the patient and the family brings in something. That's what we do at Arachnoiditis Hope. We've actually got a doctor's packet that we'll send to any doctor that's got our protocol just for the doctors. In other words, rather than, in my opinion, rather than hoping that the government or Congress, for God's sake, is going to do something, we're far better us all getting together and figure out what can we do to, help them in Maine and Miami, educate the doctors and find some help for everyone.
Yeah.
And frankly, it's working. It's slow. It's not nothing, not galloping, but we're slowly, and your program is going to help.
Yeah.
Because we're gonna take one case at a time, and we're going to get there. Everybody.
I remember years ago when I was first diagnosed, there was like no information about arachnoiditis, barely anything. And so there is obviously by your foundation, there is more information out there and, articles, books like this one I can take to my doctor.
Yeah, but they have to be willing to read it. And that's kind of the sad thing is that
Yeah, they're not always receptive, but
it truly takes my primary care physician, we talk about it every time I go in. He's like, I'm going to research this because I'm curious. And I'm like, look, if people come in with these symptoms, the first thing you should rule out is not neuropathy, because that's what I was diagnosed with initially. But you need to send them to get an MRI because that's the only way that we can diagnose it other than postmortem. And we don't want postmortem. We want antemortem, right? I mean, you want the complete opposite of that. And he's really listened to me, but it's the vast majority that we really need to get in front of and make them understand that this is such a horrible disease. It's at the top of the list of things that with pain that will never end, right? And I remember a quote that you had, Dr. Tennant, that said, the difference between cancer and arachnoiditis is upon the release of death, you have no pain. But with arachnoiditis, you just survive with it for the rest of your life until death, and it only shortens life. It doesn't kill you, sadly.
That is a sad truth, isn't it?
Yeah.
It really is. That's why the suicide rate with arachnoiditis has been terrible. In fact, that's one of the reasons why I decided to stay in this field. And incidentally, let me just, Sarah asked me how I got into all this. I told you how I got into intractable pain, but how did I get interested in arachnoiditis? It's something that you really should know. First off, my clinic evolved into a little nonprofit clinic in which we only took cases that already were way above the CDC guidelines with opioids. They had already failed standard pain treatments and were already at a high dose of opioids, so we would take them. These were rare cases, and we carried around 100 to 150 people, and they're from all over the country. And so these were rare cases. But starting in about 2005, almost 2/3 of the cases were arachnoiditis. And even though arachnoiditis is an uncommon disease, when you start taking a look at those people who needed high dose opioids, who were failing treatments, failing surgery, failing stimulators, failing pumps, failing everything, those people had adhesive arachnoiditis. So I decided to study it mainly because it was becoming very clear to me that it was the cause of the really severe intractable pain cases. And I'll stand on that in this country today, that adhesive arachnoiditis is the one disease that you may need 1,000 milligrams of morphine a day. Okay, you may need that ketamine infusion plus the opioids. You may need a pump. You may need a stimulator. You need that new dilaudid formulation. In other words, adhesive arachnoiditis has pretty well emerged in my mind as to the number one cause of those people who may need an extraordinarily high opioid dose. The only thing that comes close is we get some CRPS patients who also have terrible conditions, and then a few other sporadic causes. But adhesive arachnoiditis has emerged as the number one real cause of the people who need the most potent pain medicines.
Yeah, I agree. And that brings me to like my next question on the whole MME things, which I already know what your opinion is on it. That, I mean, obviously, I feel like it wasn't, well, actually, I know it wasn't clinically researched enough to come up with it. Like, there's no conversion to some of the meds, but they put a cap on it, in my opinion, because of the opiate epidemic, right? Which we did have, but that's been resolved. But right now, what I'm trying to say is the DNA mutation that you have, or that I have, rapid metabolism for my pain medications, in other words, do you think that patients that are chronic pain, intractable pain patients should be tested for the DNA gene mutation? I mean, shouldn't that be a standard of care?
Well, I think if you go back and look at my papers, I think what you'll see is that I did the first study on the cytochrome DNA test for people who have high dose opioids. And our conclusion was clearly that if people have this abnormal metabolism, they're going to need different dosages and the higher dosages and what have you. And so there's no question about it that somebody who is just not making it on the standard of 60, 80 milligrams of morphine equivalents a day and has got to go higher. Certainly they should be tested and that should be taken into consideration. But now let me give you another sad fact about that. Do you know that the government rejected the DNA as a legitimate test? So have the insurance companies, and the peer-reviewed journals have refused to publish the data. The data is rather hard out there, but and it's unfortunate, but that's another one of the barriers that is going to be hard to overcome, and maybe one of these days we'll get there.
Yeah.
Yeah, that goes back to the whole global warming thing. It depends on which political party is in control as to what their agenda is, right? You get the right people in the right place with the right attitude and knowledge, and not just people that thrive on conspiracy theories. And we could really change the world, I think. But it's
I think the biggest thing too is that, like, the stats are there. 25% of the population has chronic pain. To me, that is a red flag. Like, we need to be investigating why, what we can do to help, so on and so forth. And then taking away opiates, though I'm not saying that they can't cause problems and they're not needed in their time and place, but you can't just take somebody off or not leave them in agony. In other words, you can't do that. So we
I
have to find a better way.
I think I've been saying all along, I think even from our first episode and for years now, that women are most prone to arachnoiditis due to epidurals. And if you want to impact the numbers of the disease first, you need to get to the OB-GYNs or the anesthesiologists that are giving the epidurals so that they can warn these people that you have a 1 in 4 chance of actually sorry, my Doodles bark. You have a 1 in 4 chance of contracting arachnoiditis, since 25% of the population is suffering from chronic pain, and probably the vast majority that goes into the label of failed back syndrome, which is a catch-all for any type of back pain, but it's not a specific diagnosis for arachnoiditis, which they need to really dial down on.
Yeah, I mean, I agree, but like, how are we going to get the ICD-9 code back? That's my real question. Like, what do we have to do? Because truthfully, without it, like, everybody's under an umbrella diagnoses. And though, yes, we can send all of our stuff to you and you can keep track of it in ACM CRN, which can look at it on a global scale, but it's only to patients that are diagnosed. What about the patients that have failed back syndrome? So I think the stats were like 64% of them have arachnoiditis within 2 years post-op. So yeah, it just seems like it's not so small. It's not so rare of a disease. And I think you talked about that in your book, actually. That statistics are probably higher than what we once thought, maybe. Do
Oh,
you?
yeah, yes.
Yeah,
I'm
yeah,
on board with that. You
yeah,
bet.
Yeah, I
yeah,
was misdiagnosed with neuropathy for years, and then we finally got to arachnoiditis. But by that time, it was too late to really. I was so advanced that it was what it was, sadly.
yeah. Yeah, that's the sad truth. So again, how do we get the ICD-9 code changed? I mean, I can write letters all day long, but they're not going to listen to me. And I know like Dr. Eldreddy, he worked on this, right? He tried to fight against them taking away the ICD-10 code back in 2015. Um, but like you said, they have a mind of their own. They're going to do what they want to do. The other thing was about tracking arachnoiditis too, like other than sending it to your guys's. So in other words, I have a lot of patients coming to me that have had epidurals for maternity and end up with arachnoiditis. This is a huge population that I just keep seeing over and over. And my question is, have you filed this with MedWatch, FDA MedWatch? They haven't, so I tell them to file it, even though like technically they only look up to 90 days, and beyond that, I don't know if supposedly they track it, but we don't know, right? We don't see the statistics or what's going on. So do you think this, within the last 20 years, this patient population has grown to get arachnoiditis post maternity?
One has to assume that the epidurals done for delivery
Mhm.
may be associated with this increase because we have good data in our foundation. We've got lots and lots of data, and it's a ratio of about 80% of cases are women, 20% are men. So that ratio is rather skewed. So you do have to ask why. And the only thing that anybody's really seen or brought up is exactly what you brought up.
Yeah,
Okay. And let me just say something about the failed back surgery syndrome. Today, that diagnosis should never be used because
Yeah.
the new contrast MRIs, if you know what you're looking at, we've certainly figured out how to diagnose adhesive arachnoiditis. And I have just published and am publishing a few things on now how to recognize non-adhesive arachnoiditis because that precedes the adhesive arachnoiditis. And you can see that in people who have had the epidurals for childbirth or lumbar punctures. And that's something new that I'm working on myself. That's a brand new 2025 edition for Forrest Tennant is that I now am confident how to diagnose non-adhesive arachnoiditis on the MRI. Now, radiologists won't read it yet, I guarantee you,
yeah,
but I can tell the non-adhesive arachnoiditis because that's what they first get. In other words, the lumbar punctures, the epidurals, the discs that are pushing on the canal cover, the epidural itself can crack the arachnoid. So one of the new things that's come out of our research is that we can now track that you start off with plain arachnoiditis, defined simply as inflammation of the arachnoid membrane. They have to get that first and have that inflamed. And then after a while, that inflammation develops adhesions and sort of grabs the cauda equina and pulls it into the arachnoid membrane. But I'm now able to confidently look at an MRI and tell that you have plain arachnoiditis, and that should be treated. And we can do a lot of prevention because, quite frankly, but I realize that this is another uphill battle because up until we published the little handbook on MRIs, the radiologist never read the films as having adhesive arachnoiditis, and they still don't recognize one form of it very, very well. But we do have radiologists worldwide now starting to read and interpret adhesive arachnoiditis. But I'm here to tell you that you can pretty well look at the history. If they've had that epidural, they've had that lumbar puncture, and then they've got pain afterward, water dripping on their legs jerking, headaches, can't get out of bed, then you can bet that's probably non-adhesive arachnoiditis. That's diagnosable and treatable. So I'm giving you one of the newest things on my end that we've come up with.
Yeah. I was
Yeah.
initially diagnosed with chronic arachnoiditis,
Oh,
which
you
I mean, arachnoiditis in and of itself is chronic, right? It's not going anywhere. But I also have cauda equina syndrome, which is like the double whammy of pain and life-changing crud that you can get. Uh,
yeah.
yeah. So I had a spine fluid leak recently, and um, so we've got 10 minutes. Sorry. I had a spine fluid leak, and I talked to my neurosurgeon, and he said, I asked him, how many cases of arachnoiditis and CES have you seen? And he's like, not many. You're in rare air with that diagnosis. So
I
That's
just want to interject really quick because I believe, if I'm understanding what Dr. Tennant just said, if we catch non-adhesive arachnoiditis early and treat it with the steroids and Toradol, it can prevent, right? Adhesive arachnoiditis.
you bet we can.
Okay. So
okay,
that's a
early
big,
intervention.
big thing. Like,
Yeah.
yeah, that we have to, that is early prevention to become adhesive. At least so what happens whenever, because I keep having this battle with all of my doctors, and I know I'm not alone because I hear from patients all the time, but I take them in all of your research. I tell them I need steroids, and they don't listen. They won't give them to me. I don't have any other reason why I can't have them, other than they just don't want me to have them, in other words. So how do we overcome, other than keep educating or go to another doctor? Do you have any suggestions for patients that are struggling with that? Or is that really it? Just keep educating and or find another doctor or provider
So,
that.
well, finding another doctor is a good way to go. And I do think that we're identifying one doctor, one nurse practitioner a week. They are coming slowly into the fold. I
Good.
say that the trend is very positive. It's just that it's too slow for the rest of us. We want it to move faster. So we're getting there. Now, for the individual patient, I do have one message, and that is this disease is not taken serious enough. When you get inflammation inside the spinal canal, when you get inflammation in the cauda equina and in the arachnoid membrane, that's a serious, serious disease, and it needs to be looked at that way. Now, it's an inflammatory disease, and the key has to be suppressing that inflammation. Now, we haven't really found anything that suppresses that very well, except the dexamethasone or methylprednisolone, the two corticosteroids, and then Toradol. Those have been the big guns. Now, a couple of things along this line. When the doctors don't want to prescribe the corticosteroids or they don't want to prescribe Toradol, and we hear it every week, you hear it, we do have some alternative drugs and some alternative ideas, okay? The doctors may be willing to provide one of the alternatives, and I'm going to tell you what those are because a lot of people are watching your show. Diclofenac is probably the next best thing to Toradol, okay? And most of the doctors don't mind prescribing that. Pentoxifylline is one, acetazolamide is one. In other words, we do have three alternatives to Toradol: diclofenac, pentoxifylline, and acetazolamide. Those three things, and maybe the doctor would prescribe one of those, okay? We have about 4 or 5 herbal agents that are very popular because they do suppress inflammation. They're not strong enough to do the job, but they may help. If a person has diclofenac or pentoxifylline, that's Trentel, and maybe they take some quercetin and curcumin together, they may get some suppression because you've got to do something about this inflammation. You just can't say we're going to not treat it. You've got to continue to do one thing or another. I do think it's appropriate to bring up an issue here that if I don't bring it up, you're going to hear about it, and that's ivermectin.
Yes.
Okay,
Right.
ivermectin may be a game changer. Okay, now ivermectin is a drug for parasites, but it's the only drug that looks like it's really very effective against Epstein-Barr virus, which is a parasite itself. Okay, and the Epstein-Barr virus works on two mechanisms. It'll colonize your arachnoid membrane or your cauda equina, meaning it'll grow pockets there. That's how it develops cancer in certain parts of the body. If it reactivates, it'll colonize, and the ivermectin tends to get rid of it. The antiviral agents do not. But the ivermectin does something else. It's got an anti-inflammatory response that's may even be almost as good as Toradol in some cases. And that's why the ivermectin is getting to be so popular. People find they get a lot of pain relief with it because it's very potent. It's a very potent anti-inflammatory agent. Okay. Now we're also talking about neuroinflammation here now, and I'd be remiss if I didn't mention one other major point. If you go back to Dr. Aldretti's time, and they had their Congress in 2010, the one thing all the people at that conference agreed, they only agreed on 3 or 4 things. One of the things they agreed on, and they said that people with adhesive arachnoiditis develop what they called secondary pain. Okay. Now, what they meant was you start off with this pain in the back that comes and goes, ebbs and flows, radiates down your legs sometimes, radiates up to your head sometimes. But then at some point, all of a sudden, you've got constant 24/7 pain. It never goes away. It doesn't ever flow. And they call that secondary pain. Now, today, we now call that centralized pain. Okay. And the mechanism for this is the development of neuroinflammation in the glial cells of the brain. Okay. In other words, when we think that maybe the viruses or the autoimmunity causes inflammation in the central nervous system, i.e. the brain, as well as in the lower spinal column. So when we're talking about inflammation, we're also talking about trying to suppress or control inflammation inside the brain as well as in the lower spinal canal. Okay. And ivermectin is going to get more and more popular. For one thing, you can get it without a prescription. And
I was going to ask you how.
Yeah.
I tried to get this the other day because both me and my son have history of EBV, but I could only find it as a horse paste unless I tried to get it off market somewhere.
You can find injectable like at a co-op feed store. I mean, so and you can B12 is the same thing. I did B12 back in the day, and it was meant for horses, but it's the same thing. It's just a different label, and they say not for human consumption. However, anyway, we have 2.5 minutes, so let's start wrapping up. I would say this, Dr. Tennant, thank you so much for the opportunity to talk to you. I know this was shortened. We didn't get near what.
I know. I'm like, I got through like nothing, but that's okay.
If there's ever a possibility of doing a follow-up or a part 2, we would love to have you back because you were such a wealth of knowledge. and we need that knowledge to be out there because knowledge equals change equals education, and
Empowerment. Yeah.
we're all three here to help people. I think that's our mission, and we don't say that lightly. So
Well, let me put it this way. You two are the ideal people to do this. You've got the disease. You're also both very photogenic and articulate, and we need you. Okay?
thank you
And if
so
you want
much.
me back in a week or two, I'm
Yes.
happy to come back and do
Sure.
so.
Yeah,
Uh,
love that.
and because they're gonna, you're just the ideal people to do this, and I'd support you. And you just call me back and whenever you need another week or two,
Okay.
and
Sounds good.
happy to share whatever we've got. Just one other couple of things that you might want to know about. Uh, we just concluded the conference in Colorado, and tomorrow on Amazon you can buy the compendium.
Oh, okay.
Okay,
So
and it's on
we'll put the link
Amazon
in.
tomorrow. Yes. Also, it's a little complex, but our foundation's starting to write some reports because we can now have them cross-referenced right along with the peer-reviewed journals. And I've got a report out, for example, on Epstein-Barr right now that talks about when to use the ivermectin and what the dosages are and some of these things. So we're going to share these things, and you
Good.
guys are there to help.
Yes,
Well,
absolutely. We'll keep
thank you so
sending
much.
patients your
Yeah.
way
Thank
for
you for
sure.
your dedication. And I'm going to go ahead and hit the stop button.